Hi, Dr. Psutka.
Good morning, Daryl. How are you?
I'm good. I hope you are too. Um, Welcome to the conference. Grateful for you to be here. Can you tell us what kind of doctor you are and where you practice?
Sure. So I'm a urologic oncologist, which means I'm a surgeon who takes care of patients with cancers in the urinary tract, including prostate cancer, and I work at the University of Washington.
So, at the university, you're teaching mostly or seeing patients mostly?
So I am a full-time clinical provider, so I see patients in clinic 2 days a week and operate 2 days a week, and then have 1 day a week that's mostly research. But we're teaching as we work, as most academic institutions are. So when you come to a university, oftentimes you'll see the attending provider, and then we'll often have trainees with us.
Yeah, and the trainees are paying attention to the patient and will speak to you afterwards and perhaps even contribute some of their insights around what they see as care for the patient. So,
Absolutely. Yeah, our trainees are licensed physicians. They all have their MDs or their DOs, and they are in essentially their apprenticeship or their specialty training for whatever their future career is going to be. So the folks who are training with me are in a 6-year urology residency, or beyond that, as I did, another 2-year fellowship in oncology. And so they'll often be the people who are the kind of the first point of contact for patients. And then they assist us, for example, on surgeries, and are very involved in patient care, and really take ownership for patient care in partnership with and under the guidance of the attendings.
yeah, I mean, it's sort of not all that obvious, but when a patient is in a teaching hospital, I mean, you're almost getting a conference around your care every time somebody walks into your room,
Mm-hmm.
and that's very cool. That and also we had another speaker talk. We tried to figure out how many years you spend training, and after a BA, we came to like 15 years for most urologists, and that's also sort of not well understood. I mean, it's a lot of years before you sort of get to be the urological oncologist.
Yeah, yeah, no,
Yeah,
definitely. I think it was 4 years of medical school, 6 years of residency, and then 2 years of fellowship. So it's
yeah,
not a small amount.
yeah. So today, let's talk about what patients should do, think about, care about, express to their doctors, sort of after they're diagnosed and initially treated, in the sense of what they can be in charge of. As you mentioned earlier to me, the sense of agency that a patient's both entitled to and can exercise in the course of their care until the day they die after they're diagnosed.
Well, I think that when I think about one thing that I always hope that I can give to patients, I think that the moment when somebody is diagnosed with cancer is a really, obviously, it's a terrible moment. It's a moment that is associated with the feeling that control and agency has been stripped away. All of a sudden, whoever you are, your definition of yourself has changed in some way, shape, or form. But I do think it's very important to recognize that even in the midst of that transition and that assumption of a new identity, I guess, you are also still in control of a lot of things. It may not be the same way that it was before, but it's important to recognize all of the things that you still can control. And I think it's important to understand what the definition of a cancer survivor is. A cancer survivor, one becomes a cancer survivor from the time of diagnosis, during treatment, and after treatment. And then that is an identity that one assumes for the rest of their life. And so in being a cancer survivor, we want to make sure that we're paying attention to all of the things that sort of affect you differently in that space acutely early on as you're going through the diagnosis, treatment, choose the point when you're choosing your treatment, and how you're and going through the therapy, and then especially both in the early phase of recovery and then late phases of recovery, or sort of more remotely from the time of actual treatment. And so I work with patients very much to make sure that they kind of understand all the things that they're in the driver's seat for, and all of the things that they can control that will maximize their outcomes, because there's a lot that you can do as a patient to really make sure that you are optimizing, or giving yourself the best possible shot here.
Yeah, and the idea of becoming a survivor. I mean, when you meet with guys, and whether they're in your office alone or with spouses and partners or friends or what have you, is there a resistance to the term of survivor?
I haven't so much. I think that there's sometimes patients are surprised when we use that term. I don't know that I would say it's resistance as much, although being a survivor is associated with a number of other kind of feelings that can bring out. And some patients, for example, express a lot of what's called survivor guilt or survivor anxiety, but may not use those terms directly. So I try to speak very openly about all of those different facets, because I think it's important to acknowledge that being a survivor and having had the diagnosis of cancer does give, I think, patients there is the potential, there is a lot of anxiety that comes with it. There's a lot of fear of cancer coming back. There's a lot of fear of what sort of is coming forward, and sometimes there can be a lot of guilt around why I was the one who survived when others did not, and that can be very anxiety provoking for some patients. So we try to talk about that fairly openly and normalize it. And I think that I actually had this experience yesterday in clinic where I had a couple of patients who hit, 2 and 3 year benchmarks after their treatment and are still disease free. And they kind of owned that title of survivorship for the first time, saying, oh yeah, this is my anniversary. I've kind of gotten through that initial really high risk 2 year period, and you see the joy, which is kind of a nice thing. And also just the recognition of kind of what they've gone through. Sometimes you can almost forget as you're going through the treatment and the therapy and the intensive surveillance, just how burdensome that is. And patients go through it, kind of, they put their heads down and they just get through it. And then they kind of come through and they realize all that they've accomplished. And I think that paying note to that can be really empowering. And so I
Yeah.
try to acknowledge that.
Yeah, it sort of reminds me of the commercial for the First Lady's documentary on CNN. There's a clip of Michelle Obama speaking to an audience and suggesting everyone should be comfortable with a little greatness. You should be comfortable that you've survived, that you've gotten past your diagnosis and you've woken up this morning to smile during the day. One of the quandaries of a support group is that patients see others pass away, and the survivor guilt, anxiety, the lack of understanding of the progression of the disease in some bodies and then in your own is mostly different, and quite unique, which is why, it's so important to have a great doctor, tailoring treatments for you.
Yeah, I couldn't agree more. I think I like that, actually. It's sort of acknowledging one's own greatness. And I think that there's, I think in a life, in a lot of different arenas, we always look to the finish line, but there's something to be said for really kind of enjoying the race. And not that I'm saying one should enjoy a diagnosis of cancer or going through the treatment, but one must live well during that time. And so I try to find ways with my patients to help them be present and live their life as they're going through the therapy, and not just put life on hold and wait to live life until after therapy is complete. Because in a lot of cases, as I'm sure many of the audience members know, therapy is ongoing, and in some cases it's just sort of moving from one to another, but you don't want to put your life on hold as you're going through that. You want to still be present, be living your life as you're going through treatment and then recovery.
Yeah, and living a longer life is good, but living a happier life is really the goal of our organization, the support groups. I mean, there's not much, I'm a social worker. Most of the people leading our groups are psychologists or social workers. That we're not, offering new molecules and, varieties of interventions and such. What we're, in terms of concrete care, we're talking about helping people sort of invigorate their joie de vivre, their enjoyment of life, and understand it in the context of having a disease that they have to manage and be aware of, and work in tandem with professionals that they didn't ever imagine would be in their lives, let alone their adult lives and such. Yeah.
And I think that there has been a bit of a shift as we've acknowledged the importance of quality of life and given ourselves the permission to acknowledge that the permission to prioritize quality of life. I think that sometimes patients who are facing a diagnosis of cancer, they can feel almost like in prioritizing quality over quantity, they might be giving up, or they might be letting their families down because they're not maybe going for the home run, they're going for the thing that's likely to make them the most comfortable. And that's why even like the diagnosis at some point to say, you know what, my route now changes. Now I am not moving towards looking for a cure. I'm looking towards palliation, and making that choice. While that can be the right thing for a patient, patients sometimes feel a tremendous amount of stress, anxiety, guilt, burden in making that choice because they feel like they're letting the people around them down, or they feel like they're giving up, when truly that's not giving up. That's in prioritizing one's own quality of life, and in prioritizing one's own priorities and the things that are the most important to them. That's taking agency. That's making a decision that is correct for you, and nobody can tell you what's the right choice for you but you. So I think that it's important that patients feel empowered to make the decision that is right for them. And that's something that's where things like shared decision making with your provider come in, where you sit down and you have to really understand, what are the risks of everything that we're talking about me going through, and how's that going to affect me now, and how's that going to affect me in 5 years, and how's that going to affect me in 10 years, and what does life look like if I take those different paths. And that's kind of the essence of survivorship, right? It's understanding not just that sort of what are the percentages in the clinical trial if I take this drug versus the other. That's one part of it, but the other part of it is, what does life look like, and which of those lives is more right for me.
Yeah, well said. What are some of the tools or thinkings or ways of that patients can actually be in the driver's seat?
Well, I think so. From a decision making standpoint, I think one, it's important to be one's own advocate, and I think a big part of that is having insight into what matters. So I never ask a patient to make a decision quickly, especially a new diagnosis of prostate cancer. I think that that's a decision. One, we know that we have time to make a decision that makes sense for patients. So patients don't have to. This is not a burning building that you have to run into or run out of. A new diagnosis of prostate cancer is a serious diagnosis, but you have at least 6 weeks to make a thoughtful decision, for the most part. And in some cases, there's data that suggests that one just needs to make a decision in localized disease within about 3 to 4 months without any change in outcomes. So during that time, that's not just time sort of that's time for patients to take advantage of and say, okay, what matters to me? And this is a time to really be honest with oneself about what are your priorities? Is your priority maintaining, for example, so urinary continence? Would you be okay with a short-term period where you're likely to lose that, in hopes that in the long term your urinary health and function will be more stable? Or is it something where you really, that's really just not, that's a non-starter? You cannot possibly think about the fact that you might need to wear diapers or Depends or a pad for some period of time, and there's a risk of complete and utter incontinence. This is a time to think about what priorities are in terms of pain control, in terms of time off of work. This is a time to think about things like financial toxicity and have open discussions with your physicians about what the implications of taking 15 minutes to 20 minutes of therapy a day over 8 weeks looks like, as opposed to a 6-week sort of time off of more roughly 6 weeks of time off work as you're recovering from an operation. So it's a moment when you kind of have to understand and really speak with your physician about what does the acute therapy look like, what are the clear risks of those therapies, and how do they stack up. And then and the other thing I think is thinking again about what are those priorities. Is my priority maintaining independence and making sure that I get back to work the exact same way that I started and at this time point? Or am I maybe later in life, am I thinking about maintaining my health and my independence and ability to live independently? What are my worries about lack of mobility? Should you be further on in life? So again, it's taking sort of stock of where you're at, where you want to be, and then having a very frank discussion with your physician about what these treatment options that you're discussing mean for potentially interfering with those priorities.
How do you have that discussion when there are so many time constraints these days?
Well, I think that's a hard part of it. And at least in my practice, I would say that I do a lot of phone calls outside of work because sometimes you can't fit this into a quick visit. I also sometimes in my practice we run a little bit late if somebody needs a bit more time. And I think that one thing at least my patients know about me is that when I'm with you, I'm going to answer all your questions. And if we need to set up another appointment because we get through, however much time we have and we need more time and we're not done, then we set up another visit to have them come back or do a telehealth visit. I've been doing a ton of telehealth in the setting of COVID, and that's actually been very convenient for these long conversations because we can actually easily add another one on and it doesn't have the patient have to leave work or leave home and come across town or come across the state to see me in person. We can still have a very detailed, we're all getting much better at this mode of conversation, just as you and I are doing right now. So that's probably actually been one of the silver linings has been the ramp up of telehealth during COVID, that we've been allowed to do this a little bit more. But I mean, it's just a priority. You can't not have those conversations. And if patients don't feel like they're getting enough information, then they need to find somewhere where they can get the good information, because these decisions can't be made without being fully informed, or they shouldn't be, I don't think.
Yeah, and good that you mentioned the telehealth thing, because I mean, absolutely, this has become like a revelation for most. I mean, we've been here. I've been hearing. I can't say we, since we're distributed in our homes and apartments now. But the idea that you don't have to do a phone call, you could do a visual kind of thing, and the patient is at home in a relaxed setting. It's a different level of blood pressure than when they're sitting in your office. It's a different thing to be able to, pull up a piece of paper or something, or have somebody, sort of cueing you with questions or say, ask that, and it's almost ideal in a way. You could take notes in a way that you couldn't, that's more difficult and challenging in an office. And there's an intimacy through these kind of like, video chats that is missing from, or is challenging in an office setting. The battle for eye contact, the battle.
It's less, to some degree, it's a little bit less threatening. There's a little bit more space. And the other thing that I love is that I've been able to do a lot of these really, I take care of a lot of patients who are sort of at all points on the spectrum for the cancers I treat. And I treat a lot of, for example, advanced bladder cancer and kidney cancer as well. So I can have a patient who may be in Washington, but they have a daughter in Boston and a son in Florida, and we can actually teleconference and have everybody online at the same time. And then the patient has other people listening who would definitely not be able to be in clinic with them. And it's not like we have them, on the phone, sort of on speaker, trying to pay attention and listen over the rustling of papers. We can actually have a really good conversation. So and then I know this is not a visit to talk about telehealth, but it's definitely something that I think has actually improved my ability to counsel patients in this way, because it's actually been very, very helpful. And again, I think that things like financial toxicity can't be understated. It's a big deal for somebody to take a half a day off work to come, or more. I mean, I have patients who fly from Alaska to see me to have a conversation. If I can just do a visit with them without them jumping on a plane and spending $1,000 or more for a 20-minute visit, then that's much better for all of us. And we can have a conversation. And then when they come down here for treatment or whatever, it's not just, I guess I'm very respectful of what the burden is for patients to come to see me. And so I like the fact that with telehealth, we can mitigate a lot of that.
Yeah. Yeah. And, it's not a sidebar discussion in the sense that by reducing a variety of toxicities, not just financial, but the burden of time, the burden of anxiety, the enhanced anxiety of attending an office setting, or, for most people, I mean, some people will probably virtually in our audience are saying, I never have a problem going to an office or, I mean, but that's, great, but that's, it's not like going for a beer, you're sitting in a medical office talking about something that may take your life sooner rather than later. The idea of having an enhanced wherewithal to information seek and to consult and to create a relationship with the person who's taking care of you and who's engaging with you to figure out pathways towards that care. That's why when I refer to the intimacy thing, that's where that comes into play.
I agree completely. No, I think it's been, I know I find myself grasping for silver linings these days in the middle of all that we're dealing with, but I think that this is, I really have enjoyed how telehealth has transformed my practice, specifically for the counseling visits. I think that it's a great thing to have. And so I think that, as you asked me about what patients can do, you can advocate, you can say, my questions aren't answered yet. I still have questions. I still have things that I need to learn about. Ask for information, but come to those meetings prepared with an understanding of sort of what you hope to get out of them. It's because you don't want it to have just sort of a surface conversation where you're just like, oh, the risks of surgery are pain, bleeding, infection, and damage to surrounding structures. That's what people will sort of quickly run through. But it's no, what structures, like, what does that mean? So tell me more about urination. Tell me more about sexual function. We can't be embarrassed to talk about these things when we're talking about one's own functions and what that means for the rest of life. So I will often be very frank when I bring these things up to patients and say, if we talk about, for example, the bowel toxicity of radiation therapy, and bowel toxicity doesn't mean much to most patients, but saying, well, when you're going through it, a lot of times you feel like you're going to have to go to the bathroom a lot more. You may have a lot of gas. It may be uncomfortable. You may have some abdominal and intestinal distress, and sort of get into what that means. And then I think that it helps to be clear, and it helps to kind of almost demedicalize things a little bit and just talk about what this is all going to mean in the long run. Because when patients have those symptoms, they understand where they're coming from, and they're a little maybe less scary, especially if they're sort of the side effects that we can then manage. But I want patients to look out for them and not wonder if that's a side effect or not. I want them to understand, yes, that's a side effect. Now I need to tell my doctor about it so that maybe we can work on a strategy to make it a little bit less bothersome.
Yeah. Let's talk about patients in advanced stage. And there's sort of a thinking that there's less opportunity to discuss things since life really is on the line now, or at least in a more prominent way than it was, when you were initially diagnosed with a primary cancer that, presumably could be handled, with surgery, radiation, and, with the hope of cure being offered to you. The idea that the conversations about, quality of life and stuff, sort of dissipate in light of what's the point of caring whether I wear a diaper if I'm going to be dead? What's your sense of conversations in that stage?
So, and I just to make sure I'm answering the question correctly, are you talking about metastatic disease, or are you talking about diagnosis with just high risk, locally advanced?
No. Metastatic or oligometastatic, where guys, post treatment have rising PSA, maybe scans are positive or not, but there's a presumption, and certainly there's concern and fear in the patient.
Yeah, well, when you're starting to talk about the diagnosis of metastatic disease, I kind of, first of all, we talk about all the different therapy options. And now we're getting into the realm where we're not just talking about surgery or radiation, we're talking about androgen deprivation. That's something that I actually spend a lot of time talking to men about. Like, when we start talking about taking away testosterone, I get very detailed with what they can expect, because there's a lot of problems with androgen deprivation. And I think that for a long time, maybe we didn't as seriously as we weren't as serious as we should have been in terms of how we really got into what that means for a man. And so I think there's a paper that I think about from a long time ago where men were surveyed as to what they were actually told when they were starting ADT, and they were told, oh, you'll lose your sex drive, you'll lose your erections, you might get hot flashes. But then there's all the stuff that people feel, and that's things like intense anxiety, fatigue, sometimes worsening depression, cognitive dysfunction, having muddy thinking. All of a sudden, these new aches and pains, these changes in their body and how it looks, the fact that, you know, muscle mass is lost, bone mass is lost, the cardiovascular side effects, and so on and so forth. And I think it's important to have a very detailed conversation about what those all mean. And this, though, is where I really get into, okay, here's how we're going to try to handle these side effects. And here's what you can do to make some of these side effects a little bit, you may not be able to make them go away completely, but we can hopefully make them much less burdensome. So this is where we really start talking about maintaining a healthy lifestyle. I talk a lot about diet, talk a lot about nutrition, protein supplementation, mitigating the loss of muscle mass, which is critical. And that's a special area of interest in my research program, is understanding sarcopenia and the loss of muscle and what that means to somebody who's going through cancer treatment. But so that's kind of a personal focus as well. But I spend a lot of time, we go through sort of the recommendations for nutrition. We go through physical activity recommendations and sort of the recommendations for both weight bearing activity as well as our aerobic activity. We talk about ways to think about and handle the cognitive implications. And I talk a lot very openly about, you know, people's mood. And I check in with them about how they're feeling about that, because I think that, you know, we have to be very aware of the risks of depression and suicidality in patients who are on these drugs. So that's, I think, again, having an awareness and using the language, like talking about these things openly, as opposed to having a patient wonder if that's related or not related, or is that just the new norm? And then, because there are things that can be done to target each of those symptoms and try to decrease the severity of them.
Yeah, and it's for the patient to ask, or for what do you think? The patient should be asking, doctors should be offering, some hybrid?
I think in an ideal world, I don't think you can expect a patient to ask about all these things, because how would somebody who is not trained in this field know to ask about how they're cognitively going to? And now that's not saying that patients don't, because I have a lot of very well-read patients who come in and they have incredibly insightful questions, and they come in and they're ready to talk about all this. But I have other patients who maybe haven't spent as much time and maybe don't have as high a level of, say, healthcare literacy, or just don't have the language. They don't, or maybe are embarrassed to talk about these things. So I try to offer the language and open the door to a fairly detailed discussion about these. And the other thing is, you can't just get through it all at once. Again, it's something that you have to kind of reinforce and make it normal to talk about things like erectile dysfunction, make it normal to talk about urinary complaints, make it normal to be sort of talking about things like hot flashes or breast tenderness in a man. So I think ultimately, I see it as my responsibility to start that discussion and to make that discussion an intentional and detailed and thoughtful discussion, to kind of lead a patient through that. But I'm always willing to engage with patients where they are.
Mhm.
And if they're kind of only here and can only handle so much information on one specific day, then we focus on what their priorities are. But I do try to make sure that I'm always assessing all of these different things and not just sort of doing a surface kind of a platitude, giving a
Yeah,
platitude as to when I'm summarizing what this could mean for life.
yeah, no, I'm perfect. One of the negatives of this new shared decision making kind of banter we're all having is that there's no real clear protocol or paradigm for it, and it creates this within the support group setting. We see perhaps much more than a physician would see, the differentiation between adjustment to being a cancer survivor versus the burden of being a cancer survivor. The burden illustrated by information gathering, understanding the information, the obligation to speak up, the obligation to share aspects of their personality or their goals or their miseries that they've never I mean, these are guys in their 50s, 60s, 70s who may never have done that before, for whatever reason. How many times have I or you or anyone talked about the smell of urine in our pants? I mean, or so, this is, it's good when a doctor asks. And I think that's a rare physician who has a checklist, like a pilot would have a takeoff and landing checklist. The ideal would be the doctor should have a checklist, and,
Is it?
they, there are, but I mean, in
Yeah.
practice, that's not play. And usually that falls to the nurse practitioner or the intake person or whoever to go through that. And the doctor treating may never hear that and may oversight, just because in the course of the day, you have a lot of things to do.
Sure. Well, there's a really important concept in survivorship medicine that's the concept of distress. And I think that that's something that probably isn't necessarily a part of, it's certainly not, it's not something that I remember ever hearing about when I was in training, where people actually defined distress in cancer. And I think that it's really important that the physician asks a patient about that. And the distress it's multifactorial, right? It comes from kind of, it's the psychological burden of everything that a patient is dealing with in having a diagnosis, maybe being a survivor, hopefully being a survivor, all of the treatment burden, and navigating this whole new world that they've been forced into. And distress increases and decreases in sort of the trajectory of disease, and it can be sort of more related to one factor than another at any different point. But I think it's important, most importantly, just to ask patients what about that distress and how that's affecting their life. And there are distress surveys that have been validated that we can use, and I do think that there's a growing appreciation for what survivorship medicine looks like. But it's something that, it's interesting. It's very specialized, and so I do recognize that there's a lot for, in saying, we're going to do shared decision making, that puts a lot of pressure on patients. I think it still needs to be led by someone who does this in an intentional way on the professional side. My goal in this job is to partner with my patients. And my hope is that I can give my patients some sense and put control back in their lap, both feel that they have control, but actually have control, and work with them to give them the best possible outcomes. But again, that outcome is defined by them, by a man, the patient with the prostate cancer. If what is his priority is kind of what we shoot for. It's not what my priority is or what some clinical trials priority is. Um, my job is to understand what his priority is, and then to give him all the tools and sort of support the sort of the path, guide us on that path, so that we can hopefully maintain and achieve that. But it's not straightforward.
Yeah. In the time we have remaining, let's talk a bit about gender, racial, and perhaps age disparities. What do you see? I mean, let's start with the top one, racial disparity. I mean, prostate cancer kills Black men at 2.4 times the rate as it does white men. Um, and our organization is like a pioneer in understanding and developing interventions for Black men of all, whether it's Afro-Caribbean or African American or just men of African descent on a global basis, not just in the United States. The idea of physician-patient conversation, how does racial disparity, cultural understanding play into your conversations with patients?
I think that's a really important question. I've personally worked in a lot of different environments. The first 3 years of my career before I came and was recruited to UW, I actually worked in Chicago at Cook County Hospital, which is a large public institution. It's an inner city hospital in Chicago that is focused essentially on caring for underinsured um, and patients who have relative, in general, the patient population that is treated there is relatively low resourced. They don't have a lot of resources, and they don't have a lot of support, and a lot of times, um, and we treated a very diverse patient population, sort of folks from all different racial and ethnic backgrounds. Again, when I meet a patient, one of my first priorities is just to kind of get to know them and sort of what their level of understanding of their diseases and what are their priorities. And some of those will be informed by the cultures in which they were raised and that they live. I think, again, I don't know that I wouldn't even dare to make any sweeping generalizations, but I think that I do have honest conversations with patients about sort of the risk of prostate cancer and high risk disease specifically conferred by, for example, having African American ancestry, and some of that we don't fully understand sort of why. And I think that I think patients are always like, well, why is that? And the truth is we don't know. We know that there's potentially some genetic predisposition that's been passed, that is passed differentially in different racial and ethnic groups. And so we just have to acknowledge that. But I talk to patients a lot about sort of making sure that we're acknowledging that in terms of risk stratifying. I guess my point here is I don't make any assumptions about what a patient's priorities are going to be based on what they look like. Every patient in front of me is an individual, and I just try to understand what matters to them based on their race, their religion, their ethnicity, their culture, their background, where they're coming from, and then try to meet their needs. But I wouldn't say that I acknowledge that there are very strong disparities. I guess in my practice, everyone gets treated. I try my best to make sure everyone gets treated equally, and I try to meet patients where they are, but I don't make any assumptions about where they are based on where they're kind of coming from, if that makes any sense.
Yeah, and good that you say patients are treated equally. Some doctors will say, I treat all my patients the same, which is a different concept. I mean, the same for a white male doctor is as if saying, I treat all my patients like the white male patients that I imagine I'm treating in my head and that I've grown up sort of internally understanding. That's different than treating people equally, which is to give an equal opportunity to present themselves and offer the opportunity to understand. Same thing for sexual identity. Gay men struggle to be out in any doctor setting, dentist, anywhere, wherever, for whatever reason, being gay differentiates a pathway towards treatment compared to a straight person or a heterosexual person.
That's really important. And I have a number of patients who are members of the trans community. And that's a really challenging, this is a really hard diagnosis to navigate in that setting. And even prostate cancer screening in a trans woman is hard, right? Because that's not something that they might not be thinking about, or it's a completely, and in many ways, it's not something that's well described. There are very few papers on how we should appropriately handle and care for members of that community. So it's difficult. I think that in terms of there's no one size fits all model, and that's truthfully, I mean, there shouldn't be in oncology. Again, we have to understand patients' individual priorities. I do feel very strongly about making sure, though, that people have equal opportunities for therapies. And then I think that it's a question of making sure that you're tailoring your counseling to level of understanding, not making assumptions. I really feel strongly about equal representation in clinical trials. So making sure that patients who historically have not been given chances to get onto trials, like patients in the Black community, patients who are racial or ethnic minorities, they are historically very much under enrolled to clinical trials that are very important, because then we don't know whether or not those clinical trials, the results of those, can be generalized to those patient populations. But I also understand the historical context and the mistrust of the medical establishment based on abuses of certain patient populations. If we think about things like Tuskegee, that inform a patient's decision making about whether or not they enter a trial. So there's a lot to navigate there, but we want to make sure that, for example, all patients are offered the same opportunities, And then, when you're navigating, for example, disparities in, say, finances. So I treat a lot of patients who are dealing with homelessness. That's a whole different story in terms of how we think about, where is somebody going to be discharged after surgery? How do we make sure that they have the right resources to care for themselves while they have a catheter? So on and so forth. So I'm not sure that these are not easy questions, but they require sort of an intentional, we have to be very intentional on how we handle them. And my goal is just when I see a patient in front of me, I try my very best to make sure I'm, again, understanding what matters to that man, talking to him in a way that he feels like he understands what we've talked about at the end of the conversation, and and then sort of making sure that we keep a conversational sort of dialogue open, because this becomes a lifelong relationship inevitably.
Thank you very much for this conversation. I'm sure our audience feels uplifted a little bit, illuminated a lot, and certainly motivated to sort of consider how they can improve their relationship with their doctors this day forward. So thank you for that, and welcome to our conference.
Well, thank you so much. I appreciate the opportunity to speak with you today. It's been a pleasure.